Febrile seizure. Key points. Most febrile seizures are benign and do not require investigations. Management includes identifying the source of the infection and treating if indicated. Antipyretics have not been shown to reduce the risk of further febrile seizures. Background. Seizure in child without previous afebrile seizures, without significant prior neurological abnormality and without signs of CNS infection or metabolic disturbance. Usually occur between 6 months and 6 years of age. Benign. Occur in 3% of healthy children. Normally associated with simple viral infections. Occur without previous afebrile seizures, no significant prior neurological abnormality and no signs of CNS infection. Recurrence rate depends on the age of the child. The younger the child at the time of the initial seizure, the greater the risk of a further febrile seizure. 1-year-old 50%, 2 years old 30%. Classification. Simple febrile seizure. Fever and of the following, all of the following. Generalise tonic-clonic. Seizure. Duration of less than 15 minutes. Complete recovery within 1 hour. Do not recur within the same febrile illness. Complex febrile seizure. Fever and any of the following. Focal features at onset during the seizure. Duration greater than 15 minutes. Incomplete recovery within 1 hour. Recurrence within the same febrile illness. Afebrile febrile seizure. Seizures in an acute infectious illness, particularly gastroenteritis, without documented fever. Features consistent with simple febrile seizure. Risk factors for developing subsequent epilepsy include family history of epilepsy, any neurodevelopmental problem, prolonged or focal febrile seizures, febrile status epilepticus. No risk factors, 1% risk of developing epilepsy, similar to population risk. Risk increases with more risk factors, up to 10%. Assessment. Blank. In addition, look for the following risk factors which make simple febrile seizure unlikely. And LT 6 months of age, consider blank. And GT 6 years of age. Any features of a complex febrile seizure. Blank. Previous afebrile seizures. Progressive neurological conditions. Developmental delay or regression. Management. Investigations. No investigations are indicated in a simple febrile seizure, where the focus of infection can be identified clinically and the child returns to baseline mental state. Investigations for the source of fever, including lumbar puncture, should be guided by the nature of the presentation and age of the child. C. There is no role for EEG in simple febrile seizures and a limited role in complex febrile seizures. In a prolonged or focal febrile seizure, consider CNS imaging after consultation with a senior doctor. Treatment. Blank. Manage the underlying blank. Manage the underlying cause of the blank. Consider consultation with local pediatric team when seizures unable to be controlled. Complex febrile seizure. Child does not return to normal mental state within 1 hour. Child clinically unwell. Ongoing concern regarding the nature of the febrile illness. Frequent seizures, for consideration of anticonvulsants if indicated. Consider transfer when respiratory or hemodynamic compromise, status epilepticus, failure to return to neurological baseline. Children requiring care above the level of comfort of the local hospital. Consider discharge when return to normal neurological state following simple febrile seizure. Serious bacterial infection excluded or adequately treated. Underlying illness managed appropriately. Parents aware of first aid advice and management of possible subsequent seizures. Discharge information. Blank. Follow-up as required for the underlying illness. It may be appropriate to offer a review appointment with a general pediatrician, especially if complex or recurrent febrile convulsions,